this lecture, we're going to be talking about the embryonic period. So here we're going to talk about isotretinoin teratogenicity. Remember, there's a 3 to 8 week period, and it's a bit broader than this. Every organ system is a bit different. But generally speaking, there's a 3 to 8 week period called the critical period of embryogenesis, where there's a lot of signaling going on and a lot of cross communication. Isotretinoin is a retinoic isotretinoin, or Accutane, as some of you might know it. It can be used to treat acne, very severe acne. So isotretinoin, or Accutane, interferes with retinoic acid signaling. It interferes with retinoic acid signaling, and that can cause a lot of birth defects, such as missing limbs. And I just want you to stick that in the back of your head for now and keep it in mind. So at the beginning of the 3rd week of development, the ectodermal germ layer is shaped sort of like this fat disc, right? So you have it narrower here and a bit chunkier up there. So this is the cephalic side. This is cephalic. And this is caudal. So in the caudal region, it's narrower. In the cephalic region, it's broader. Once the notochord is formed, we're going to start getting thickening of the overlying ectoderm. So this is going to all start to thicken as the notochord, remember, it's developing underneath the ectoderm. It's going to thicken everything out. All right, so what I want you to imagine is the neuroectoderm, right? That thickened neuroectoderm that formed. Imagine that it's the palm of my hand, and the back of my hand is going to be just different tissue. All right, but the neuroectoderm is the part that has thickened and raised up, and it's the flat of my hand, and it's going to fold on itself. It's going to fold, and when it folds, it's going to get inside. All right, so it's going to fold and then become a tube inside. And you can sort of see that happening here. You have this neural fold, and you have the cut edge of the amnion here, and you have a groove, right? So if I do this, my pinkies, that line in between my pinkies is the neural groove, or the tip of this, the bottom of this V that I've formed is the neural groove. And the folds are going to come up and wrap around, right? The folds are going to come up, and you can see them beginning to wrap around, and the somites are beginning to form. All right? That's what I want to emphasize here. And they're going to extend cranially and caudally. They're going to go cranially and caudally. So this ongoing process of the folding is going to be what forms the neural tube. So everything's going to fold until it completely encirculates, until it completely wraps around. So here again, you have the cut edge of the amnion. Notice it's completely wrapped around. It has completely wrapped around. It was flat, and now it's completely wrapped. It's like you've wrapped, if you took a flat pita bread and rolled it on, it's brought both edges over to wrap on top. So that's the neural fold up here. You can see the pericardial bulge, the otic placote. This will give rise to the things you need to hear for balance. So the structures needed for the senses of hearing and your vestibular sense, your balancing sense, those are going to come from the otic placote. Here you have your somites, and we'll talk more about those later. But notice that fusion has begun. So these folds have merged completely here. It's fused. But no, and it proceeds in both directions, both cranially and caudally, until you have only 2 areas that are still open, the anterior neuropore and the posterior neuropore. Anterior neuropore, posterior neuropore. This needs to close, but this is where the brain is going to need to develop. This is going to close, and the brain vesicles are going to develop in here. Down here is the posterior neuropore. This needs to close. Failure of the anterior neuropore to close is going to cause anencephaly, which is embryonic lethal, which means that's not a viable pregnancy anymore. The posterior neuropore, if it fails to close, can cause spina bifida. That's high yield. You have to know that. Failure of the anterior neuropore to close can cause anencephaly. Failure of the posterior neuropore to close can cause spina bifida. So we're going to talk a little bit about the folate cycle, since that's very pertinent here, because the most common cause of spina bifida and failure of the neural tube to close, most neural tube defects are related to a deficiency in folate. So to keep it simple, folate has a cycle, and in that cycle, it interacts with vitamin B12. Folate is B9. So it interacts with vitamin B12 cobalamin, and it also interacts with nucleotides to synthesize them in their complete form. I'm skipping most of the specifics here because there'll be a different video talking about that. Generally speaking, folate has to interact with vitamin B12 in order to synthesize nucleotides. And vitamin B12 is involved with some other processes as well, including some neurolipid related processes. So the lipids that surround the neurons, cobalamin has been implicated to have some kind of role. So for the folate cycle, what we need to know is that this is a precious resource in embryogenesis. Why? Because you have a rapidly dividing embryo. It means you have so many dividing cells, so much DNA synthesis going on. You need lots of nucleotides. All right? So the mother can run a risk of becoming folate deficient. She needs to supply enough folate in her diet that that the embryo is able to synthesize the nucleotides it needs. All right? Otherwise, you can get neural tube defects. The second thing I want to point out is something called megaloblastic anemia. Megaloblastic anemia. So blood cells are also cells that are rapidly dividing, and they need these nucleotides. So when you have a deficiency of either folates, I'll use red for this, either folates, okay, for megaloblastic anemia, if either folate or vitamin B12 is deficient, you will get megaloblastic anemia because you're not able to synthesize nucleotides. However, you cannot see megaloblastic anemia and assume that it's going to be a folate deficiency and not a cobalamin deficiency. Because if you provide folate as a supplement, maybe you'll take care of the anemia part, but remember, vitamin B12 is involved with some lipid metabolism. And accumulation of lipids can affect the neurons and cause irreversible neurological complications. So if you have megaloblastic anemia, which means big red blood cells, and later you'll learn how that's categorized. But the point is you have these immature, huge red blood cells that are megaloblastic, and they're precursors. They're not what the final mature erythrocyte should look like. They're megaloblasts. And that can either be from a folate deficiency or a vitamin B12 deficiency. All right? So over here we have our anterior neuropore, and here we have our posterior neuropore. By the end of the 4th week, let me switch my laser pointer again. By the end of the 4th week, notice that we don't see either neuropore. So keep in mind, a lot of mothers don't know that they're pregnant until they've missed at least one period. And that's well after the neural tube closes. So that's why it's important to supplement folate in the diet so that mothers, even if don't know that they're pregnant, there's still enough dietary folate. So a woman of childbearing age should have enough folate in her diet. That way, in case she's pregnant, there's no defects to the baby. Additionally, one of the unfortunate things about the fact that the neural tube doesn't close until 28 days is that there's susceptibility to other things like alcohol things that cause fetal. And there's a lot of other stuff that isn't just happening in the 4th week. This is called neurulation, when the neural tube forms and then closes. It's neurulation. Let me write this. Neurulation. So that's just one of the processes, but there are other things that can get impacted. And let's say you're drinking alcohol and you don't know that you're pregnant. You can cause the fetal alcohol syndrome, which you'll learn about later. So Here we have the lens placode. This is going to give rise to the lens, believe it or not. We already discussed the otic placode. Here we have the pharyngeal arches. This is the limb bridge. You can see the heart bulge, the vitelline duct, and the allantois within the umbilical cord. Eventually, the amnion is going to surround everything except this part of the umbilical cord. So it's going to cover the top of the fetus, the back of the fetus, this side of the fetus. Imagine if my laser pointer could go behind this image on the plane. So that side of the fetus, everything is going to be covered by the ventral body wall, except for at the point of the umbilical cord. All right. So as the neural folds are elevating, you can see they form crests. And I referenced the crest slightly in my last video, but you can see that they're forming crests here. These neural crest cells, before the tube closes, are going to give rise to the glia, the Schwann cells, and the neurons for everything involving the the craniofacial region. So the melanocytes of this part of the craniofacial region of the skin, the glial cells that are going to go there, the neurons for cranial ganglia, Schwann cells, all of this is going to come before the neural tube closes. All right. After the neural tube closes, cells can migrate in one of two directions. They can either go, so here they're going ventrally. This is the back, and this is ventrally. So they can either go dorsally, which is going this way, or ventrally, which is going that way. If they're going dorsally, they're going to contribute to the melanocytes of the skin and the hair. All right? You don't need to memorize that. You don't need to memorize that. Now, if they're going to go ventrally, they're going to contribute to the dorsal root ganglia. They're going to contribute to the para-aortic ganglia. They're going to contribute to the sympathetic ganglia, the adrenal medulla, the parasympathetic innervation of the enteric ganglia. What else? The I'm blanking on it right now. And they're going to go through the ventral part of the somite. So that's what I want you to sort of conceptualize right now. I'm going to tell you, we haven't reviewed the somites yet, but I'm going to tell you that the somite is going to be involved in giving rise to the vertebra and the ribs. Okay? The somite is going to be involved in giving rise to the vertebra and ribs. So when you look at this, I want you to imagine that you're looking down into a human being, and the neural tube is the spinal cord. This paraxial mesoderm that's given rise to the somites, so these somites here are going to think of them as like ribs, okay? Ribs and muscles, all the supporting stuff that's going to be there. Over here is the notochord, which is going to give you your nucleus pulposus. And ahead of it, so if we look at this diagram, it's probably better, you can see the aorta, all right? So you can see there's the organization of where the organs are going to be has already begun. And if you can understand that and understand how things are migrating, there's less anatomy for you to memorize. For example, these neural crest cells are migrating ventrally, and they're going to form the sympathetic ganglion, and they're going to continue to migrate into the adrenal gland, the medulla. They're going to continue to migrate into the preaortic ganglion, and they're going to continue to migrate into the enteric ganglia to form the enteric nervous system. All right, and over here, this is just showing crest cells. This is the neural tube, this is the notochord, and the crest cells are migrating this way. Induction, so for the neural crest cells to even migrate though, the neural tube up here and the surface ectoderm communicate. So this surface ectoderm over here, I'm going to color it blue for you. This surface ectoderm has to communicate with the underlying neural tube, and that's what generates the neural crest cells that are then going to migrate. So there's three that I want to emphasize from this list. The parasympathetic ganglia, just because it's going to be involved in our discussion of Hirschsprung disease. So the parasympathetic ganglia of the GI tract. The adrenal medulla, because the adrenal medulla is a neural crest cell, but the adrenal cortex is mesoderm. The adrenal cortex is going to make lipid hormones, the sex steroids, the glucocorticoids, the mineralocorticoids, whereas the adrenal medulla is making catecholamines like epinephrine and norepinephrine. And it's no coincidence that the adrenal medulla is making norepinephrine when it's a neural crest cell derivative, and norepinephrine is a neurotransmitter in the brain. So it retains its sort of neuro background. The melanocytes are also important just because examiners love to go after it. You know, melanocytes are neural crest cell derivatives, so they'll give you a question stem with melanoma and they'll say, what's the derivative? You have to know it's a neural crest cell. All right? Examiners just like it. It's NBME food. All right. So let's talk about Hirschsprung's disease. In Hirschsprung's disease, I want you to sort of imagine the GI tract, the way it loops back and forth, and it's a tube, right? The GI tract is a long tube, and the crest cells have to travel throughout it, okay? The last place um, that gets innervated, or not the crest cells have to travel, the crest cells make the ganglia, but the parasympathetic neurons connected to those ganglia have to travel throughout it as as the GI tract develops. And the issue becomes the latest parts, the parts that develop last, are all the way at the end of the tube in the hindgut, are most susceptible to losing their innervation. If that happens, normally the parasympathetic innervation of the end of the GI tract keeps everything nice and toned, and you get good peristalsis and you're able to excrete feces, and all's well and good. However, let's say for some reason the parasympathetics don't actually innervate the end of the GI tract. What happens is you'll get a dilation in this area and constipation, and you'll get a backup. Everything's in a backup, so you're going to have issues with feeding, you're going to have bloating, constipation, etc., because you don't have peristalsis here. All right, so that's Hirschsprung's disease. You get this megacolon because there's no active innervation, parasympathetic innervation of the distal end of the colon. Okay, similar to Hirschsprung's disease, but a bit different, is Chagas, because Chagas is the direct killing. It's a parasite called Trypanosome cruzi. So it's a trypanosome spread by the reduvid bug, and this is something they can ask you on an exam. All right, you can be tested on this if they want to cheese you on the infectious disease portion. So Chagas disease is spread by the reduvid bug, the bite of the reduvid bug, which transmits the trypanosome. All right. What this does, first of all, can cause dilated cardiomyopathy, so heart problems. And it can also cause constipation and issues with swallowing. What it does is that it can destroy the parasympathetics. And it's not as straightforward as that, but let's leave it at that for now, just for the purpose of our discussion. It's going to destroy the parasympathetics. So if Hirschsprung's disease is an embryological issue where the parasympathetics never really properly developed, Chagas disease is when those parasympathetics get killed off or destroyed by the parasite, and you get the same outcome. All right? So those are two concepts I wanted to illustrate. And we talked a bit about melanoma, so I'm not going to belabor the point too much. Just do know it's a neural crest cell derivative. I cannot emphasize this enough. As the neural crest cells migrate, notice how they're going to come fill the facial region. These are the pharyngeal arches here, but there's not much else on the slide I want you to know. I just want you to recognize how the crest cells are going to migrate, how they're migrating over. So in summary, the ectoderm gives rise to the central nervous system, the peripheral nervous system, the sensory epithelium of the ear, nose, and eye, the epidermis, including the hair and nails. It also makes the subcutaneous glands, the mammary glands, the pituitary gland, and the enamel of the teeth. So I know we didn't discuss all of these, but these are all the derivatives of the ectoderm. Pretty much all of these are face or brain related, except for the sub-Q glands and the mammary glands. and the hair and nails. But that you should know because the ectoderm is making the skin. Odds are it's making the hair and nails, right? It's all the integumentary system. So think integumentary system, things in the craniofacial region, um, that includes the teeth, the pituitary gland, and then the subcutaneous glands and mammary glands. And the subcu glands are associated with the skin, so you can loop those two together. So it's really just the mammary glands that are the one-off one that you just sort of got to memorize. But even that, you can say that the mammary glands are right below the skin of the breast. So, you know, there's ways to do it. Okay, so over here, we're looking at day 17, 19, and 20 and 21 of the mesoderm. 17, 9, let me put my laser pointer. 17, 19, 20, and 21. So here you can see that the mesoderm is on either side of the notochord and it's very thin and very loose. By the 17th day, the cells closest to the midline proliferate, and you can see that here, to form a thickened plate of tissue called the paraxial mesoderm. Paraaxial because it's along the plane of the axis of the notochord. More laterally, it's going to stay thin and it's going to form a plate. And I wish there was a way to make this pointer smaller. But what I want to emphasize here, you see this little opening that's forming, these little cavities? So this area is going to become confluent. So you have these little breaks in the lateral, this thin lateral plate mesoderm. This is lateral mesoderm here, lateral mesoderm here. It's going to form these little breaks, and those little breaks are going to start to come together, and you can see that this turns into an opening, right? You have a little opening here, here, and here, and that's made by these little intercellular cavities, these little white regions, right? So like areas of white are just forming inside, but that's happening up here. And that is what's going to give rise to the intraembryonic cavity, because this area is going to get bigger, right? And then some folding is going to occur, right? Some folding is going to occur. You have parietal mesoderm here, right? This is all parietal mesoderm. So you have your paraxial and your parietal. They're different. How are they different? Because the parietal came from the lateral plate mesoderm. This is the paraxial. This is the lateral. The part that goes up and associates with the amniotic cavity is the parietal mesoderm layer, okay? The part that comes up and associates with the amniotic cavity is the parietal mesoderm layer. The part that goes down and associates with the yolk sac and the endoderm is the visceral mesoderm layer. The reason it's called visceral is because it's associated with the viscera. If you're eviscerated, your guts come out. So this is the visceral mesoderm layer. It's associated with the guts. Your parietal mesoderm layer, parietal, that means far. That's going to make your body wall. That's going to contribute to your external and internal obliques and your transversus abdominis muscles. All right? So we have these two layers, and you have this intraembryonic cavity, and it's not sealed off yet. All right, and you have this intermediate mesoderm that's connecting the paraxial mesoderm and the lateral plate mesoderm. All right, by the beginning of the third week, the paraxial mesoderm is going to split into segments, and those are called somaitomeres. And they're going to go, and this process starts cephalically and goes caudally, and we'll see that on the next slide. Once they pass into the occipital region, they're going to organize into somites. And this isn't something I want you to memorize, but there's 8 cervical somites, 12 thoracic somites, and 5 lumbar somites, which happily happen to coincide with the amount of spinal nerves. You have 8 cervical spinal nerves. You have 12 thoracic spinal nerves. You have 5 lumbar spinal nerves. Okay, convenient, very convenient, especially considering the fact that the neural crest cells are going to form ganglia and have to pass through the anterior part of the somites. It's so great that there's 8 cervical somites, that 8 cervical, you know what I mean? So there's not too much to memorize if you visualize things. The dorsal root ganglia are going to form somewhere over here. I don't have my laser pointer on. The dorsal root ganglia are going to have to form by migrating through this region, and this region is going to form the structures that surround them. All right, so everything's related. Everything is related. It's beautiful. So I don't want you to memorize the number of somites, but they just happen to correspond to the spinal nerves. And there are more in the sacral and coccygeal region, but we're not going to worry about those right now. Um, so here's how it works. When the somites first form, they're just a clump of mesenchymal-like fibroblast cells. Um, in other words, they're mesenchymal means loose, connectivity. It doesn't have this well-defined structure. And the transition in between can be called the epithelial to mesenchymal transition. In this case, it's epithelialization because the mesenchymal cells are becoming epithelialization. Epithelialization, the process of becoming epithelial or like epithelial cells. So they undergo that process so they can take on a more definitive arrangement. Sometimes the opposite happens, and it commonly happens before cells have to migrate. So cells that have to migrate will often undergo the epithelial to mesenchymal transition, or the parenchymal to mesenchymal transition. And cancer cells do this often, so that's why I'm bringing it up here. Because what that means is you're now loose and you're free and you can get out of the basement membrane. So the epithelial to mesenchymal transition is something to keep in the back of your head. But you don't need to worry about it too much for now. So when the somites are first forming, they're just a clump of mesenchymal fibroblast-like cells. Um, you can see them here. Here's your neural tube. Here's your intermediate mesoderm, your intermediate mesoderm. Your parietal lateral plate mesoderm is going up to associate with the amniotic cavity. Your visceral lateral plate mesoderm is coming down. It's going to come down to associate with the yolk sac, okay? The visceral layer is going to associate with the yolk sac and the endoderm, okay? It's visceral. It's going to surround the guts. All right. So let's take a look at around day 28, which is over here, the cells in the ventral and medial walls of the somite. Okay, over here, they're going to become mesenchymal again. I'm telling you they're becoming mesenchymal. That means they're going to migrate. All right? They're going to shift to surround the neural tube and the notochord. Okay? And remember, this is happening on both sides, but I'm just illustrating it. It's the drawing only has it illustrated here. Okay, so this region, which I'm going to color light blue, is going to give rise to the sclerotome. Okay? It's going to surround the neural tube and the notochord and differentiate into the sclerotome. And that'll become the vertebra and the ribs. Okay, the sclerotome will give rise to the vertebra and the ribs. And it's such a great coincidence that they happen to be surrounding the spinal cord, right? Yeah. So you have your ventromedial. Ventromedial. Now, the cells at the dorsomedial and ventrolateral, so I'm going to use yellow for that, dorsomedial, back and middle, and front and lateral, ventrolateral, front and to the side, dorsomedial, back in the middle. So the dorsomedial and ventrolateral muscles, somite cells, will differentiate into the precursors for the musculature, okay, as shown over here. All right, the ventrolateral will become the sclerotome. The ventromedial will become the muscle precursors. Okay, and that's not too important to memorize. Okay, that's not too important to memorize. I just want you to be aware of it. Okay, there's going to be another round of epithelial to mesenchymal transition where the ventrolateral muscle cells and dorsomedial muscle cells will migrate under the dermatome. Oh yeah, and what's in the middle over here that I'm going to color in green, this is going to become the dermatome over here, okay? So here's the dermatome, and here's the myotome, and here's the sclerotome. You can see some of the sclerotome has gone back here, okay? And it continues to occur, and you see you have your myotome and your dermatome, and that is how you're going to get your muscles in your skin. So both muscle cell groups are going to become mesenchymal in order to do these migrations, all right, to form the dermomyotome. And the ventrolateral cells are going to do something else. They're not just going to form the dermomyotome. the ventrolateral cells will migrate into the parietal layer. So this parietal layer here, the ventrolateral, so these guys over here will migrate into the parietal. So these guys over here are going to migrate with the parietal lateral plate mesoderm. And that's going to be what forms. Remember how I mentioned how the parietal mesoderm eventually is going to form the external oblique and the internal oblique and the transversus abdominis. This is what I'm talking about. So it's going to migrate alongside the ventrolateral muscle cell precursors, and you don't have to memorize that. You won't be tested on that most likely. But those muscle cells are going to form the muscles of the body wall and the muscles of the limbs. So by the end of everything I just described, we formed the precursors for the dermis of the skin of the back, the muscles for the back, the muscles for the body wall, and some of the limb muscles. And each myotome and dermatome retained its innervation from its segment of origin. So the third somite is going to keep its innervation. That's important, and we'll see why in a second. So the fact that muscles retain and skin retains its original neurological innervation allows us to do something really cool on our physical exam. By testing where different skin sensations are intact, you can tell where in the spinal cord the problem might be. Because wherever the skin isn't feeling something, let's say there's a patch of skin on the inner arm here, that's going to correspond to a specific part of the spinal cord, whatever innervated it during development. Okay? Same goes for reflexes, the muscles. So for example, you can test C5 and C6, those spinal nerves, by hitting an elbow. All right? Or not the elbow, but testing the biceps reflex to flex at the elbow. So you're going to hit the tendon will stretch, the biceps will contract a little bit, and if that reflex is absent only on the right hand side, um, that can indicate that in the context of other physical exam findings, that can give you information about what's going on at the level of C5 and C6 of the spinal cord. Before we had MRIs, this is all we had. We didn't always have MRIs. Okay, we didn't always have CTs. We didn't always have X-rays. So the neurological physical exam uses these principles. This is also why referred pain exists, because if two organs migrate to different places, for example, the diaphragm, if it's irritated, the pain can be referred higher. Why? Because the diaphragm develops around those somites, the C3, C4, C5 somites, and it has to descend. And because of the descent of the even though the diaphragm descends, it's not innervated by the thoracic or the lumbar nerves. No, it keeps its innervation from its original somites, whatever innervated the original somites. So it keeps its innervation from C3, C4, C5, which keep the diaphragm alive. Okay, that's the saying. C3, C4, C5 keeps the diaphragm alive. But irritation of the diaphragm can represent as pain higher up. It can be referred to a different region of the body that is also innervated. That can happen with the heart. You get a heart attack. Where does the pain radiate? It radiates to the left arm or shoulder. Gallbladder pain can radiate suprascapulally. So there's a lot of stuff that is a consequence of the migration of these muscle groups. And that's why I'm emphasizing it. I'm not telling you this so you can write down the ventrolateral joins the parietal. That's not what I want you to take away from this. I just want you to develop an appreciation of the embryologic processes that create the anatomy that we study and use to treat patients. The intermediate mesoderm is going to give rise to the genital and urinary structures, and I'm not going to talk about it right now just because we're going to go into more detail later. Okay, so we talked about the lateral plate mesoderm. Mesoderm you can see here. This is the parietal, this is all parietal, and this is the amniotic cavity in here, right? Amniotic cavity in here. But what's going to happen is these are going to fuse, all right? This is going to pinch off, all right? Here's the endoderm of the yolk sac. Here's the ectoderm. Here's the parietal mesoderm layer. This is going to fuse, so this red and this blue and this red and this blue, they're fusing together. And this red and this red is fusing together. So you now have a continuous amniotic cavity. Okay, and that was due to the action of the parietal lateral plate mesoderm. All right, now let's talk about the visceral mesoderm. Okay, here's our visceral mesoderm layer. Notice here that you now have a mesentery. All right, that's what the GI tract is suspended from, the mesentery. Now here you have your visceral mesoderm layer, and it's enwrapped in the endoderm, and together they're forming the wall of the gut. So this is visceral mesoderm. And this parietal mesoderm that folded down continues over here, and this forms the peritoneum. This forms the peritoneum. So mesoderm from the parietal layer together with the overlying ectoderm form the lateral body wall folds. These are the folds of the lateral these are the folds of the lateral body wall. These are the folds here. These are the folds. Okay? And what's not drawn here is, so we're looking at this embryo sort of sideways. So it's like this, and I'm looking at it from here. Like it's like this is like a tilted cross section. It was cut in half. If the embryo is facing me, I cut it in half. My sandwich was facing me this way. I cut it in half, and I'm looking down, and I tilted it. And that's what we're seeing here. So what I want you to visualize is if there's a tail going back this way, there's like a tail, right? Pretend that there's like a tail over here, okay? And that there's a head somewhere. If this were to continue, if you were to extend the blue in 3D out of the plane of the slide, you would get to the head. And the tail and the head are also folding. Those regions, the amniotic sac is going to be folding there as well. But what we're focused on here are the lateral body wall folds, where the ectoderm is associated with the parietal mesoderm layer. Okay? So the mesoderm is going to give rise to the bones of the limbs, the connective tissue of the limbs, the dermis of the skin and the body wall and the limbs, the sternum. Okay? Migrating sclerotome and muscle precursors that we already talked about are going to form the costal cartilage, the limb muscles, most of the body wall muscles. So notice the trend that the mesoderm is giving rise to the things that let you move around, right? To an extent. It's also going to give rise to the genitals and the urinary system. But aside from those, what the intermediate mesoderm does, it's also going to form sort of the muscular and bone structures, all right, and the skin, or not the skin, my bad. All right. So these, so as I was saying, the dermis, I just remembered something, that's why I stopped. I didn't have this originally in the script, but I'm going to bring it up now. Dermis and epidermis are different. The dermis is coming from the mesoderm. And there are some other contributions as well, particularly for the back, the dermis of the back. But the epidermis is ectodermal. It's pure. The epidermis is ectodermal. Okay, epidermis, ectodermal. Um, so, anyways, just wanted to clear that up because it just popped into my head while I was sitting here. So so like we said, the migrating sclerotome is going to come make all the stuff. And the visceral mesoderm and the embryonic endoderm are going to form the walls of the gut tube over here. Now, the mesoderm of the parietal layer surrounding the intraembryonic cavity, so this parietal layer here, this parietal mesoderm here, this is visceral mesoderm here, this is mesentery connecting the two, but this parietal mesoderm here is going to form mesothelial membranes. So as more body cavities develop, which we'll talk about in a different lecture, you're going to form the lining of the peritoneal, pleural, and pericardial cavities and secrete serous fluid. That's what the parietal mesoderm is going to do. So the serous lining of the peritoneal, pleura, and pericardial cavities comes from the parietal mesoderm. Now, the mesoderm of the visceral layer is going to form a very small layer around each organ. Remember, the visceral mesoderm is what surrounds the organs. The parietal mesoderm is parietal. It surrounds the cavities. All right. I just want to talk a bit about how blood vessels form. So in vasculogenesis, vessels arise from blood islands. So you have these random blood islands you see here, and vessels arise from them. In angiogenesis, vessels will sprout new vessels. So there's sort of a branching going on. So vasculogenesis, you get new vessels from blood island. Angiogenesis, you get new vessels from pre-existing ones. All right? The first blood islands are going to show up in the mesoderm at around 3 weeks of development. Okay? So at about 3 weeks, they're going to show up in the yolk sac. This isn't, hold on, let me put this here. Okay. At around 3 weeks, they're going to show up in the yolk sac. Now, these islands are going to arise from mesoderm cells that were induced to form hemangioblasts. Don't worry about that right now. What I really want you to understand is although the yolk sac is where the first blood cells come from, okay, although the yolk sac is where the first blood cells come from, the definitive hematopoietic stem cells emerge from the mesoderm surrounding the aorta at the aorta gonad mesonephros region. Okay, let me write that out for you. The aorta gonad mesonephros region. And most importantly, and this is critically high yield, is that these will migrate to the liver in the second month. Okay? So for the 2 to 7 months, those definitive hematopoietic stem cells that arose in the aorta gonad mesonephros are going to be in the liver, and that's extremely important. The liver is a hematopoietic organ between 2 to 7 months. Why is that important? Because there are conditions in which the liver can become hematopoietic again. All right? That's called extramedullary hematopoiesis. We're not going to talk about what causes bone marrow suppression, but when bone marrow suppression occurs, or any failure of the bone marrow occurs, hematopoietic stem cells need to be made somewhere, and they will be made in the liver and to a degree in the spleen. And that's extramedullary hematopoiesis. Why medullary? Because medullary bone is what encases the marrow. So extramedullary means outside of the bone marrow. So bone marrow suppression will lead to liver and spleen extramedullary hematopoiesis, and that will cause hepatosplenomegaly. And that can be a physical exam finding. So if you're suspecting leukemia that has led to bone marrow fibrosis or something like that, or like a polycythemia leading to bone marrow fibrosis, or essential thrombocytopenia leading to bone marrow suppression, or any of these, any cause of bone marrow suppression. Don't worry about that right now. What I want you to focus on is that the liver and the spleen can undergo extramedullary hematopoiesis, and the liver in 2 to 7 months of embryonic life, in the 2nd to 7 months before the hematopoietic stem cells migrate to the bone marrow, they're in the liver. The only thing I want you to know about hemangiomas are that you can monitor them and they tend to regress. They're just proliferations of dense capillary networks, and they tend to regress on their own. They can be surgically removed or medically treated if, like with this baby on the right, if it's interfering with function. So the GI tract is going to be the main organ system derived from the endoderm, okay? It covers the ventral surface of the embryo. Okay, this is the dorsal, this is ventral. So it's covering the ventral surface, and this is the cranial, and this is the caudal. Okay, notice that the umbilical cord is connecting, or not the umbilical cord, the connecting stalk, which will become the umbilical cord, is coming in near the caudal end. Okay, so as the brain vesicles begin to develop, the embryonic disc begins to bulge into the amniotic cavity. So you're starting to bulge. This bulge is happening here. This is the bulge into the amniotic cavity. It's pushing into the amniotic cavity. And lengthening of the neural tube. See how the neural tube is lengthening here? In C? Okay. Lengthening of the neural tube causes the embryo to curve into the fetal position as the head and tail are going to move ventrally. And notice as these move ventrally, they're pulling the amnion down with them. Okay, so this pushes down. These are pushing down as they're pushing down, you have your lateral plate mesoderm over here, right? Your lateral plate mesoderm. As they're pushing down, it's bringing down the amniotic cavity. All right? Okay. So the embryo, by the end of that process, once this fully comes in, you can see that the yolk sac has been gradually getting phased out, and the embryo is becoming inside of the amniotic cavity. It's entirely inside the amniotic cavity. All right. The only thing that's still open is the vitelline duct, the vitelline duct. Okay. The event. So over here, we're seeing again the lateral body wall folds all over again. We saw this. I described what was happening in here earlier. All right. So the ventral body wall is going to close completely except for the umbilical region where the connecting stalk and the yolk sac are going to stay attached. Okay. The connecting duct and the yolk sac duct or the vitelline duct are going to remain attached. Failure of the lateral body wall to fold is going to cause defects, and that's going to be discussed in a later video. As a result of cephalocaudal growth and closure of the lateral body wall folds, more and more of the endodermal germ layer is being incorporated into the body of the embryo to form the gut tube. So as this closes, that's what's being illustrated here, more and more of the endoderm until it's almost completely involved over here, it's going to form a gut tube. It's not really a gut tube, kind of forming a gut tube, complete gut tube, right? There's this pinching off that occurs. There's this pinching off that occurs, and the gut tube forms. So the gut tube is composed of the foregut, the midgut, and the hindgut. And the midgut is going to be what communicates with the yolk sac by way of a broad stalk called the vitelline duct, which I've mentioned earlier. Now, the midgut is going to give rise to the small intestine. And the vitelline duct needs to regress. So let's say this is the small intestine, et cetera, and this is the area of the vitelline duct. This needs to regress or become this like fibrous structure that isn't a tube anymore. Like you can't communicate through it. And if you don't, you'll get a Meckel diverticulum. So the problem with a Meckel diverticulum is that it can either open up into the world, which is bad because that's a source of infection um, and leakage, but also it can cause a pouch. Okay, that's the Meckel diverticulum. It's the pouch that's the diverticulum. This is not the Meckel diverticulum. This is just one consequence of the vitelline duct staying open. The Meckel diverticulum is a pouch. Okay, it's a pouch. Let me draw this down. Meckel diverticulum is a pouch. And this can be a nidus for inflammation. All right? You can see all the derivatives of the endoderm here, the pharyngeal gut, the tracheobronchular diverticulum, which is going to give off the lung bud, the esophagus, stomach, the pancreas, the liver, the gallbladder, all this stuff, right? Intestinal loop, hindgut, cloaca, etc. Okay? So at the end of the day, the endoderm gives rise to the epithelial lining of the respiratory tract, the GI tract, the parenchyma of the thyroid, the parathyroid, the liver, and the pancreas, the reticular stroma of the tonsils and the thymus, and the epithelial lining of the urinary bladder and urethra, and the epithelial lining of the tympanic cavity and auditory tube. So even though the excretory structures are going to come from the mesoderm, the intermediate mesoderm, the epithelial lining of the bladder and the urethra is going to come from the endoderm. That's just something I want to point out. So by the beginning of the 4th week, the forelimbs and the hindlimbs appear as these paddle-shaped buds, all right? The former are located more dorsally, okay, to the pericardial swelling. So the heart swells out over here, and the forelimb sort of fin, if you want to call it that, is going to be dorsal to that. Okay? They're going to be at the level of the 4th cervical to the 1st thoracic somites. And that is why the limbs are innervated by the brachial plexus. Okay? You don't have to memorize that the brachial plexus innervates the limbs. You can understand that it is inevitable for the brachial plexus to innervate the limbs because embryologically, So not the limbs, the forelimbs, the upper limbs, the upper extremities. It's inevitable because embryologically they're sitting right behind the heart from the level of the fourth cervical somite down to T1, the first thoracic somite. And those nerves are going to contribute to the brachial plexus, and those are going to be what innervates the upper extremities. You don't have to memorize it. You can visualize it. You can visualize it. All right? Always try to do that. Make things as easy as possible. Reduce the amount you need to memorize. All right. So the hind limb buds appear later than the forelimb buds, but you don't need to know that. And they're caudal to the attachment of the umbilical stalk. So they're down by the lumbar and sacral areas, and that's why the lumbar and sacral nerves are going to innervate those lower extremities. So eventually those flippers are going to become flat, and they're going to go, certain parts are going to become apoptotic, and you're going to form these little ridges, and these are going to sort of die. So I'm going to put a white to show over here, like these areas are just going to die off by apoptosis, and that's important. That's insanely high yield, and you need to know that the webbed fingers, if a child is born with webbed fingers, it's a failure of apoptosis in this region that I just drew all those lines on. All right? Apoptosis, or programmed cell death, breaks down these webbed fingers and this tail. So there's it's important to know that. Examiners like to ask that. They'll say a failure of which of the following, and you'd have to say apoptosis of the interdigital blah blah blah. Okay? And that's all. Thank you. This was the last of the longer lectures.